cloud. Okay, share screen. You have to love technology, but it is sometimes extremely frustrating when everything has to work. Okay, thank you all for showing enough interest in learning more about biostatistics and research methods to come to almost a 2-hour session on a Friday morning. I know you all are very busy, and I know that this shows dedication on your behalf to try to improve the way that you either critique the literature in your field or perform your own research and interpret the results. My name is Jo Wick. I'm a faculty member in the Department of Biostatistics. I actually sent you a set of slides that had our old department name. Recently, we added the term data science because we have a lot of individuals in our department who are truly data scientists. I am not a data scientist. I feel like I'm strictly a statistician. So I don't really know a lot about high dimensional data, a lot of the genomics type research that some of you may be doing, but I do know a lot about statistical methods for clinical and translational research, which is the topic of the 4 lectures or sessions that we'll have over the next 5 weeks. So for those of you who didn't know that we had a Department of Biostatistics and Data Science, we do. We're hidden up on the 5th floor of Robinson, which is when you go through Murphy. It's the building on the corner there that has an elevator and that's kind of hidden off. We house about 15 statisticians, PhD level statisticians and data scientists, along with a couple other master's level statisticians. We do a lot of clinical research, translational research. We also have a genomics presence, an informatics presence, if you will, with some individuals who, again, I mentioned are truly data scientists as opposed to just statisticians. So if you ever need statistical support, there are a couple of ways to do that. You can go to our department's webpage, and you'll see up on the top left-hand corner a project registration link. If you have, even if it's just a student research project, you're welcome to use that project registration link because we do a lot of collaborative research. We have a project management team, and that can schedule you some one-on-one time with one of our faculty or staff to discuss the issues that you have with your protocol or your grant application. We do that first initial meeting in kind, so it's free of charge. If you do have other needs, we'll try to get them to you in the most economically feasible way, and let you know about maybe resources that can help support you all in the development of studies and the conduct and analysis of studies. We also, in addition to the faculty and staff support, we have a biostatistics tutoring lab, which is at the ground floor of Robinson, directly under our department. And that is open on Fridays during the academic semester, the graduate school academic semester. And if you're a student or a resident or a fellow and you have a research project, you have a protocol that you're developing for something that you're doing over the summer, our PhD students are sitting down there ready to help you. If you're taking a stats class and you have problems with homework, our PhD students are down there to help you. If it's something that they feel they're not comfortable with, they'll escalate it up to me, and then I can talk to you all about what's going on. So just to let you know, those resources are there. If you have a question or you don't know how to access them, feel free to contact me by email, and I'll help direct you towards those. So all of the sessions that we're having in the next 4 sessions over 5 weeks will be recorded, and I will make sure that those links get sent to you all directly if you're on the registration list. So even if you're here and you didn't register, make sure you go in and register. That way we have your email. I did send out all the course materials last night with the wrong department name because the name just changed. But nothing else has been changed content-wise. So I want to make sure that we frame the purpose of this course. The purpose of this course is to probably refresh your memory about all the different kinds of statistical tools you can use when looking at research studies. But I also want to reiterate to you all, or introduce to you all, the idea of uncertainty, and that nothing that we ever do proves the truth of something, that there is always some kind of uncertainty associated with the design of our research study, the execution of our research study, the data that's generated, the analysis and the interpretation. And how do we quantify that? How do we control that uncertainty, manage that uncertainty, and communicate that uncertainty in a way that we don't, for instance, overstate our conclusions or understate our conclusions, for that matter? It also, when you think about uncertainty and the things that can happen in any of the phases of clinical research that would produce uncertainty or additional uncertainty, it helps you be a better consumer of the literature, the clinical trials or the research literature. So keeping in mind, what kind of study design was it? What are the strengths and limitations and features of that study design that could potentially cause the result that's produced by a particular study to be a false positive or a false negative? And how do you know when an article that you're reading is truly interpreting the findings of their study in the right way? So we're going to talk about the usual things. We're going to talk about chance, bias, random variation, confounding. But more than that, we're going to talk about, just in general, how to start thinking like an evidence-based practitioner of whatever field you're in. We're going to start this week with just an introduction, just core concepts. We're going to look at some terminology, some examples to try to start thinking about ways that studies can be flawed or strengthened by changing certain aspects of the study. And normally in this first week, I have our Director of Research IT come and talk to you all about the non-statistical resources that our department provides, whether it be data management or something else. But he unfortunately was unable to make it today. So this lecture is going to be a little bit shorter. He usually has about 20 minutes. If it's too short and you guys are still, we're still chugging along and nobody's asleep, then we might go ahead and go into the next week's lecture. But if not, we can dismiss early. And I'll have Dinesh, who is our Director of Research IT, maybe just podcast the information for you all. So again, core concepts will be today. We're not really going to talk about statistical tests today. That will come in the last 3 weeks, and we'll focus on going through things like linear regression, tests of proportions, tests of means, survival analysis through examples and things like that. But the purpose of this class is not to turn you into a statistician, but to get you thinking about how you use statistics in your own practice, and thinking about the proper way of interpreting the results that you might produce from applying statistical methods to your research data. So the term statistics, the field of statistics, the science of statistics, does have an actual definition. So when we say statistics, often we think about all the methodology. But statistics, the science, is actually the application of mathematical concepts and rules of probability and chance to facilitate decision-making when we don't know the truth, when we don't see 100% of the information, anytime there's uncertainty, which that, by definition, is what we do in medical research. So some questions that you might need to address, either through a research project or in your practice, could have to do with, for instance, predicting a patient's long-term chances of successfully quitting smoking, depending on what kind of therapy you're going to give them. So we answer that question using statistical methods, statistical regression models. You might also be interested in more of a public health question. Not that that one's not a public health question, but it's for a specific patient, right? You might be interested in just learning more about a population like the United States and estimating the prevalence of a condition like obesity. And then you might also be interested in comparing different interventions or different treatments to see which one maybe is optimal for a patient population. So I have an example of that here too, comparing the effects of a surgical and a medical treatment for coronary heart disease. When we talk about statistics, the science, we have three major branches. We have the branch in here in the middle called experimental design. So people kind of forget that statistics really is the driving force underneath the design of an experiment, because you have to understand how each aspect, each logistical aspect even of your study produces information. And so what we do as statisticians is we facilitate that process to make sure that the design will produce the valid information and enough information for the research question to be answered. So that includes techniques for the planning and the conduct of experiments. Most people will think about statistics in the context of design when it comes to the sample size calculation, or maybe, this is my research question, what will the statistical method look like? We'll talk about specifically, what role does a statistician or statistics play in that process later. That way it will help, I think, better prepare you when you go into a meeting, when you're doing a study design. You'll know what information to bring to that meeting in order to facilitate the designing and the estimation of your sample size. The other two components on the outer edges are what we do with the data. So we describe the data and we use the data to make decisions. So descriptive statistics is just processing, summarizing, and presenting the information contained in your data. Inferential statistics is using the information contained in your data to make a decision. And so all the statistical tests tend to fall under inferential statistics, and then any estimation and visualization falls under descriptive. But a good research project will incorporate all three of these. I shouldn't have said that, because inferential statistics sometimes is not appropriate. It just depends on the scope of the project. And again, back to statistics, how does this decision-making work? Well, we start off with a theory or a hypothesis that is informed by observation, but not very rigorous observation. Maybe we're seeing individuals in the clinic, or we're seeing things happen in the lab, and we have a hypothesis about why we're seeing what we're seeing. So you have to be able to set up a study, an experiment, to test whether or not that hypothesis is valid. And you do that by drawing, you replicate what you're seeing, you draw a sample, and then you describe the sample using summary statistics. You visualize it using things like histograms and bar plots and all other kinds of tools. And then you use the information generated by the experiment to infer back to what it is that you are seeing in terms of what's really producing the observations. The problem is that we never are able to see the truth, generally speaking. So we have to replicate this process several times, many times sometimes, to make sure that it's a robust process to even minor changes in our approach to answering the question. And the more we can replicate it under different conditions, the more confident we are that our hypothesis is valid, and the less certainty is associated with the conclusions that we draw from that investigation. So here's an example of addressing a research question. Suppose you're a researcher and you're seeing in your clinic, you're treating individuals with lung cancer, and you're asking them questions, and it turns out that you're noticing that the people that you're treating for lung cancer are also reporting a higher intake of coffee than, for instance, other individuals that you might see in your clinic. So this could generate a hypothesis, and you might want to be able to test this hypothesis to see whether or not the coffee drinking is actually associated with a greater risk of lung cancer. Now, the problem with addressing this in a scientific experiment is that it's not ethical, right? How would we want to, if we were interested in whether or not some kind of an exposure actually causes a disease or a disability, how would we have to approach that in terms of an experimental situation? So I have an exposure. I want to demonstrate that it causes lung cancer. You have to cause disease, right? Correct. So there's an ethical issue there. You'd also have to exert some kind of control over who gets exposed and who doesn't, right? So I'd have to randomly assign individuals to smoking, for instance. We all, I think, understand that smoking is associated with a higher risk of lung cancer. You'd have to randomly assign individuals to smoke or not. And that's not an ethical approach to answering that research question. So I'm going to show you later several different approaches to designing a study. I'm going to start with the most rigorous experiment. And we hate to use the word experiment when it comes to human subjects because it has a negative connotation. But we have to think back to experimental principles to develop a randomized controlled trial where you have random assignment of the exposure, the treatment, and then you put in place a lot of other conditions that would minimize the impact of bias and variation on your results to make sure that you do get as close to a causal association as possible between the exposure or the treatment of interest and the patient's outcome. But we can't do that here because it's not feasible, because it's not ethical. So this study has to be what we call observational. Anytime you remove control over treatment assignment, your study becomes observational. When you remove that protection against bias, randomization or otherwise, then you actually weaken the level of evidence that's produced by your study, because now there may be other things that are causing the association, which I'll show you here after I define experimental and observational studies. So an experimental study is when the investigator controls the exposure assignment, and an observational study is when you just observe it. So that's kind of the larger classification of study types in the hierarchy of evidence: experimental versus observational. Here we have two different exposures. We have those who, for simplicity, for the purposes of simplicity, we have exposed to coffee and unexposed to coffee, and that is not an exposure that we, as the investigator, assign. We just observe it. So when we're looking at this, we have the exposure on the left and the outcome on the right. So what we do is we observe, we classify individuals in this population into their exposure category, and then we look at the rate of lung cancer diagnosis in each of those two cohorts. Suppose once we do this in a pretty large study, we see that the rate of lung cancer diagnosis is actually higher in coffee drinkers. So it seems once we've done this observational study, it's kind of producing evidence that confirms our hypothesis that coffee is associated with a higher risk of lung cancer. But what's the problem with making that statement in an observational study? There could be a third factor at play here that's associated with both the exposure and with the outcome for the patient. Does anyone know what that third variable is called? It has a statistical term. Exactly, it's a confounder. It confounds the relationship between the exposure of interest and the outcome of interest. It could potentially be the driving factor behind the increased risk that you're seeing. It just so happens that the people who are reporting higher levels of coffee drinking are also potentially smokers. So you wouldn't know that if you didn't know to look at smoking simultaneously to measure it. So the problem with these confounders is that they may be known. In the case of smoking, we would know to look at smoking behaviors. What are other behaviors that could potentially increase an individual's lung cancer risk? Potentially, I'm just saying things that, there are other lifestyle things, right? Behavioral things. Workplace exposures. Genetics. Yeah, really anything that could increase their risk. You have to ask the question, could this be the driving factor? Well, if you know ahead of time that it could increase an individual's risk, in an observational study, you probably should be measuring those things as well, right? To make sure you don't have confounding of that known risk factor with the risk factor of interest. So coffee drinkers are more likely to smoke than non-drinkers. That is the wheel that's driving this association. And unfortunately, if it's confounded with coffee drinking, then there's no way to really tease out the effects of the two. You'd have to design your study to do that. So again, if the investigator doesn't record this known risk factor to see whether or not the coffee drinkers were also smokers, then you could draw the wrong conclusion. So the research question has to do with an association between coffee drinking and lung cancer. It turns out that there is a causal association with cigarette smoking and a non-causal association in terms of related habits between the coffee drinking and the cigarette smoking that produces the correlation between the two, the coffee drinking behavior and the lung cancer outcome. And we've already, thank you all for remembering that this is a confounder. A confounding variable is any variable, any variable that's really not of interest. It's a nuisance that is associated both with the exposure of interest and the outcome. And it's the primary source of bias in observational studies. And that's why, you know, we get a lot of really good headlines out of observational studies, don't we? Unfortunately, we don't do a good job, I think, as a scientific community of getting ahead of some of that so that we don't freak the public out, for lack of a better term. So how could we address this in an observational study? If we know that smoking is associated with lung cancer, could we build that into our study design? We can't randomize smoking. We can't randomize exposure to coffee. How could we control or manage this source of bias in the design of an observational study? You can measure it. You can also do what? Could you sample in a way that allows you to make sure that they're not confounded, right? We could purposefully sample to make sure that we have both smoking and non-smoking coffee drinkers, smoking and non-smoking individuals who don't drink coffee. And then we would be able to tease out the effects, right, of smoking and of coffee on lung cancer diagnoses. So knowing about these things ahead of time, we can manage their impact. The problem with observational studies are the confounding variables that we don't know about, and there could be many of them. So if we did this study where this is kind of the point that I was making, where if we had all the non-smokers who were also more likely to not drink coffee, then the rate of lung cancer diagnosis being higher among the coffee drinkers who also happen to more frequently be smokers could be attributed to the smoking behavior as opposed to the coffee drinking. And so if we don't, again, manage this confounder through the sampling for our observational study, then we won't be able to separate the effects of coffee from smoking, and we actually can't answer the research question. We couldn't do it at all. There's no statistical model that could allow you to test this association. It's totally confounded with smoking. What could happen here is that you produce a false positive finding, and it turns out there's a lot of research showing that observational studies tend to find things that aren't there more frequently than the studies that are experimental, simply because of this feature, because we cannot anticipate every known confounder. And so false positive findings, the statistical term for a false positive finding is known as a type 1 error. So the association's not there, but we detected one. And so we have a false positive. And this type 1 error happens because of the confounder that produces a bias in the association between drinking and the rate of lung cancer diagnosis. So the formal term bias is just any systematic deviation away from the truth. And that can be caused by, for instance, confounders. It could be caused by the way that you designed your study. It could be caused by the population that you're looking at not being the population of that you should be looking at. It could be caused by instruments that are not calibrated correctly. There are many different sources of bias. Other sources of bias could also come in just recording how a patient responds to a treatment. So if I'm an investigator and I'm really excited about this new therapy, I just know it works. And I'm also one of the individuals responsible for recording, assessing subjects' responses to that therapy and a control, which I think is subpar. Even if I'm a really good scientist, that could cloud my judgment in assessing someone's response to the therapies, right? So what do we do whenever we have that situation? What kind of design principle do we put in place to prevent that kind of bias? Blinding, right? We just remove your knowledge for your own sake, right? Because our knowledge sometimes can bias the results of a study. Here's another example of a way that a confounder could mess up or produce invalid results in an observational study. So before we had confounding, where smoking was highly associated with the exposure of interest, which meant that smokers were also more likely to drink coffee, and it's hard to tease out the effects. What if we have a confounding variable that we don't really know about, and it's in there? For instance, let's suppose that this is however many years ago, and we don't really know smoking is the causal problem here. And because we don't know that it's a factor that we should be thinking about, we don't measure it. We just don't even know that it's there. And it turns out that among our coffee drinkers, we also have this additional risk factor, but some of them have it and some of them don't. And we're not measuring it. Among those who are not drinking coffee, we have the risk factor as well. Some of them have it, some of them don't. And we don't see this middle layer, right? Because we don't even know it exists. Suppose then did I delete? Here we go. This is where I was going. Suppose then that when we look at the association, we find that the rate of lung cancer diagnosis is actually no different between the two groups. So instead of finding something, we don't find something. This could potentially produce what's called a false negative finding. Suppose coffee really does cause lung cancer, that's the truth. But we have this unknown confounding variable in there that's increasing the variation in our outcome, because it's actually not two groups I'm comparing. Each group actually has multiple subgroups who have different characteristics, different risks. And because of that, there's additional noise in the data. That can produce a false negative finding, which is called a type 2 error. And that can be associated with what's called error. Sampling variability sometimes will produce error, noise, but it's really any unexplained variation in an outcome. And the reason why we call this particular scenario error or noise as opposed to bias is because this is just increasing the noise. So it dampens the signal. We can't really see the effect of the exposure because we have our data is too noisy. And that is also another problem with observational studies, is if there are other variables that are either increasing the noise or producing bias, we could either find something that's not there or miss something that is there through either a type 1 or a type 2 error. So let me go back and make sure that there's... So what I was going to say here is a little bit more contrived, and it has to do with the power of a study. So I'm just going to skip over it. Not that smoking causing lung cancer isn't also a little bit contrived. But, so how can we fix these studies? Well, if we don't think about these things ahead of time, we can't, right? All we can do is, you know, take it in stride, learn from it, and probably not get funded by whoever funded the study again because you wasted their money. But if we think through all of the potential features, characteristics, exposures, comorbid conditions, whatever, that could produce an invalid result, either through noise or through bias, if we think about those things ahead of time and we manage them as much as we can within an ethical framework, then that's as good as we can do. And that does require time. You can't design a study quickly without giving this careful thought until you've done it many, many times, and then it might become more natural. So you have to collect information on any alternative exposures or risk factors or conditions that could result in or modify how a patient responds to treatment or increases their risk. In this particular study, we could do a number of things. We could measure their smoking behavior. We could sample in a certain way, either making sure that we stratify our sampling to have smokers and non-smokers in each of the 2 exposure groups, or we could just limit our sampling, for instance, to non-smokers. And it removes the problem of that third cog in our process. So any questions about that, the idea of bias and error, and how to start thinking about the management of those things? So again, back to this larger concept of uncertainty. All of the data that we produce is generated from a sample, right? Or samples. And those samples always come with some amount of uncertainty. So statistics provides the tools to help you manage that uncertainty through design and maybe models that can tease out effects. It also allows you to quantify the uncertainty associated with your conclusions. So what do I mean by quantify uncertainty? When we communicate a finding to either the general public or to our scientific peers, we have to tell them a level of confidence, right? We have to tell them, how confident am I that this is a real finding and not an invalid result? So the quantification of that, I already said one term that we tend to use, and that's confidence, but that can come from many different features. Things like reporting the power of your study, the type 1 and type 2 error rates of your study. So how likely was this study, in the way it was designed, how likely was it to have produced a false positive or a false negative finding? We make sure that when we design the study, we do it in a way that we incorporate an adequate sample size to address the research question to produce good characteristics of power, type 1 and type 2 error. When we report a finding, we report the significance level of that finding using something like a p-value or a confidence interval. When we have a table where we're describing characteristics maybe of either patient responses or features of our patient population, we don't just provide the average, right? We provide the average and its standard error. The standard error, the reason why we have a standard error there is because it communicates how good of an estimate that average is, and we'll talk about that more later. Confidence intervals incorporate a level of how much uncertainty is associated with the decision and the estimate that we have. And then, of course, it's up to us to also make sure that we understand what's the appropriate interpretation of the study findings in the context of the design that actually produced the evidence. So with that framework, we're going to talk about evidence-based practice. And you can remove medicine and put just about anything here. Anything that you do based on data. It could be banking, risk management, statistics, medicine, neuroscience. You know, anything that you do can be done in an evidence-based fashion. So evidence-based practice involves gathering evidence in the form of scientific data and then applying the scientific method to inform the way you do your job. In medicine, that happens to be developing new therapies, new devices, new programs, or policies that are aimed at improving health of a population. When we talk about scientific evidence, though, what do we mean by scientific evidence? Scientific evidence is just observable data, right? It's information that we can actually observe. So it's empirical evidence gathered in accordance to the scientific method, which serves to support or counter a scientific hypothesis. And there are different strengths of evidence. I alluded to that earlier. The strength of the evidence is directly dependent upon the type of study that produced it. So observational studies produce pretty weak evidence, but they might be the best that we can do if, for instance, we can't feasibly or ethically control the exposure or the treatment assignment. So I don't want to downplay the importance of some of the lower strength scientific evidence, because that's generally where we start anyway. And it might be as high as we can go for some research questions. So things like expert opinion, case reports, a single clinical example, first principles, that is the lower end of the scientific evidence scale in terms of how much should we rely on it to make decisions that ultimately impact the patient in front of us. But we do need that information to inform how we approach studies that have stronger evidence. You would never throw all of your resources at a randomized controlled trial if you hadn't already done some things in the lab, or someone else had done things in the lab and done case series or pilot studies, for instance. But as you move up, you can see we have study designs that maybe you've heard of: retrospective cohorts, case control studies, systematic reviews, prospective cohorts, and then, of course, the randomized controlled trial or systematic reviews of randomized controlled trials. The reason why they produce stronger evidence is because they're actually more labor intensive to do. They're bigger studies. They incorporate principles that minimize or manage the impact of bias and confounding, like blinding, randomization, prospective observation, real-time observation of outcomes, as opposed to asking someone to recollect what their exposure or their outcome was. So we'll talk about each of these types of studies, their strengths and weaknesses, and how to differentiate between them, just as a kind of review before we get into the statistical methods. The reason why we prefer to do evidence-based practice in anything is because it produces better outcomes. It's more efficient. Practices that are rooted in evidence-based, are those that have been shown under rigorous investigation to be superior to other alternatives. Implementing evidence-based practice, again, will, in medicine, produce a higher likelihood of successful patient outcomes, and actually will result in a more efficient use of healthcare resources. The production of evidence that facilitates evidence-based practice comes from the scientific method. So just a really quick picture where we start with observation. It might be noticing a single patient that had an interesting response to something, produces a hypothesis, and then we continue to observe until we're ready to experiment. And it could be that we do observational studies, and then at some point we've gathered enough data that this really should be tackled in an experimental fashion so we can try to really get at what's going on here. And then this is a cyclical process that usually never ends, right? We revise our hypotheses based on experimentation. And the clinical evaluation of an intervention, a therapy, a drug, it's done in the same way. It's just, again, done through observational studies and experimentation. When we conduct these studies, again, I don't want to downplay the importance of, I'm not sure why the things came up weird, but we do it in a couple of different ways, and we don't always start down here where we're trying to establish causality, because again, that usually requires building up to a certain state of knowledge before it can justify performing studies that will actually establish causality. So we start typically with descriptive studies on individuals or a series of individuals. We build into these observational studies on populations. Maybe we use Heron, the data repository that we have here that captures a lot of the electronic health record information, just to see maybe if there's evidence in the electronic medical record about our theory. And then once we have that kind of descriptive information, if it justifies moving on to experimentation, then we can do pilot studies. We can do randomized controlled studies if those, again, are feasible. But again, as we move up the purpose, it moves up with the strategy, right? Because we can't always just do pilots. Otherwise, we're never going to continue moving forward the state of knowledge. As we move forward, in terms of our strategy, we exert more control, spend more resources, and decrease the ambiguity of the results. We strengthen the level of evidence, which moves forward the state of knowledge. And we do that by the way we design our studies. So experimental design is a formal term that we use to refer to any technique for planning and conducting a study. From a statistical perspective, experimental design includes, you may have a research question. How do we turn that into a testable hypothesis? What is the testable hypothesis? Because not all hypotheses are testable. Once we have the testable hypothesis, which is the foundation of the study design, then we have to figure out, well, what are the experimental conditions? What interventions or treatments or populations are we going to look at? What outcomes reflect the patient's response to this intervention in the best manner, the most efficient and most accurate manner? So what are the measurements that we're going to collect? When will we collect them? Do we collect it a day after treatment, 5 days after treatment, 10 days, a month, 6 years? What's the timing of the measurement? And then again, almost most importantly, what other extraneous conditions do we have to manage? Can we exclude them altogether from impacting our study by maybe limiting who we allow to be in our study? Do we measure them and try to attempt to control for them in the way we randomize? Or do we just measure them and try to account for them in a statistical model? Once we have this bullet 1 and bullet 2 down, we've really thought through this. Then once we know what measurements we're collecting and what our hypothesis is, we can determine how we're going to analyze that data once it comes in. And so once we know the statistical analysis plan, we can actually determine the sample size to produce a valid result with high power and low type 1 error. So a sample size that will ensure as much as possible that we don't produce a false positive finding, that if there's not something there, that we don't say something is there. And that also, if something is there, that we don't miss it. So that's the power, the probability of detecting a signal if the signal actually exists. And that, again, the sample size calculation cannot be done until bullets 1 and 2, and even the statistical analysis plan, which is not above this, are done. Because the sample size calculation is a mathematical calculation that depends directly on how you're going to analyze your data once it's done. And then, of course, we have to know how we're assigning the subjects to the different interventions. The statistical analysis that will be performed should be above the sample size. Actually, the sample size calculation is probably the last thing. The nice thing about doing a study design, is that this is not a sequential process. Very often you do 1, and then you do 2, and 2 makes you rethink 1, and then you do 2 again, and then you do 3, which makes you rethink 1 and 2. So it takes a while, obviously, for those of you who have done it. But again, the ultimate goal, every decision that you make in the design of your study is to minimize bias and to reduce the amount of noise in the data. So you can detect a signal and you can detect it accurately. So the things that we do, that we incorporate into studies, if it's feasible and ethical, include trying to mimic a random sample, which is very difficult if you're doing clinical research, randomizing subjects to different experimental conditions, different groups, incorporating a control group, which gives us a reference for comparison to make sure that whatever is happening is associated with the treatment and not with the progression of the disease or some other feature that could be present in the control group and the treatment group. Blinding, we already talked about blinding. Remove the knowledge from either the patient, the subject, the observer who's recording the patient's or the subject's outcome, and sometimes even the statistician who's analyzing the data. It's useful for them to not be biased toward finding that meaningful result. And so if a statistician doesn't know the treatment assignment, only that they're in group 1, group 2, or group 3, that's also very useful. And then prospective observation, which just means that you're seeing things happen. You're not relying on the electronic medical record. You're not relying on patient recollection, because there's a lot of reasons why that information can be messy. So the more of these protections that we can put in place, the stronger the evidence will be produced by the study. A randomized controlled trial is the only one that incorporates all of these. Anything less than that will have one or more of these features removed. And so we'll go through the types of study designs right now. Randomized controlled trial, I have the little gold star there because it's the gold standard of evidence, but it's not always feasible. And we don't always start there. So we just have to try to manage things within the framework that is optimal for our research question. So just below a randomized controlled trial is an observational cohort study. And there are a couple of different types of observational cohort studies. All you're doing with the cohort study is well, not just that, but in some observational cohort studies, you're just removing the randomization. You're just observing the treatment, for instance, that patients are receiving, as opposed to trying to assign it. Case control is a little bit different than a cohort study. You're removing an additional protection that is prospective observation. It's usually retrospective. So it relies on recall or report of previously occurring exposures. Cross-sectional studies don't even have time. You just know that patients who have lung cancer also have this other condition. But you don't know if lung cancer happened first or this other condition happened first. You just know that they're seen together at some point in time. Case series is on individuals. Case reports also on individuals. And you often see this in the framework of what's called the hierarchy of scientific evidence. I like the pyramid because it shows you how, this is the foundation of knowledge. And as we move the state of knowledge forward, we tend to go up as far as we can. Two of the things at the top, I don't know that we'll get to them. Unfortunately, we don't usually have time in the summer, but I'll try. The systematic review and the meta-analysis. Is anyone familiar with these terms? Lots of yeses. Why do you think they're above a randomized controlled trial? Absolutely, because one randomized controlled trial is great, but it's still dependent upon a single sample, right? A single sample of patients. So we need to replicate it. And so systematic reviews and meta-analyses try to go out and find all the randomized controlled trials that were addressing a research question, manage the differences in their study designs using statistical techniques, and report a pooled answer, if that makes sense. So multiple randomized controlled trials are better than a single randomized controlled trial. But again, we probably won't get into those just because of the lack of time. So starting at the top and working our way down. So we'll start with the gold standard and then we'll remove some kind of feature of that study design to show you how it weakens the level of evidence for the block underneath it, the design that's just below it. So the randomized controlled trial, it is the gold standard. It's the only true experimental study because you are exerting control as an investigator over the exposure assignment. So when I say exposure assignment, I don't mean like you're exposing people to whatever, but you are, right? If it's a drug, you're exposing them to the drug or a different drug or a control. But basically you're exerting control over the intervention assignment, the treatment assignment. And you're doing that through randomization. We'll talk about randomization in a moment and why randomization is really the only way of doing it in a way to kind of manage, again, sources of bias and confounding. We also have the feature prospective exposure. So we are watching the subject be exposed and recording how that exposure happens. We're recording the dose. We're recording whether or not it actually happened. We're seeing it right in front of us. And then we're also we have prospective observation of the outcome. So we see the patient's response and we actually measure it, as opposed to, again, relying on previously occurring events that have been recorded in the electronic health record, or asking a physician or a patient what actually happened, because that can come with error. So prospective observation just means that we're seeing it happen. We're not relying on historical information. The direction of inquiry is not really important here. It becomes important when we try to distinguish between some observational studies. So direction of inquiry has to do with how patients are grouped or classified, and whether that classification happens based on that exposure, that treatment, or their outcome. So I'm alluding to the fact that we have cohort studies and case control studies. If you're familiar with those, you'll kind of get what I'm talking about. But just know that the direction of inquiry here is forward in time, because the groups, by definition, are formed through this randomization, right? They're randomized to the exposure. And then we follow them forward in time to observe their outcome. We also have what's called a concurrent control group. So you might see studies, pilot studies in particular, where you have a historic control. And those are good, right? But they're not optimal. If you can have a concurrent control group, that allows you to measure what changes in outcomes you might see in unexposed patients. For instance, in the placebo or the standard of care. It could be if you're treating migraines and you're seeing with this treatment magically in 2 hours, the migraines are gone. Can you say that the migraine therapy was effective from just looking at a single group of treated patients? You can't, because what else could have caused the migraines to go away? Just the migraine could go away, right? So having that control group that's untreated allows you to measure all other features and changes in these patients who are not receiving the treatment. So if you see any differences in the response patterns of those who are treated, you can attribute that to the treatment itself. And these are the only ones that can be designed to test for causal relationships between exposures and outcomes, because they do follow experimental principles. So again, some differentiation. There is some linguistics here that sometimes get glossed over. Prospective or retrospective. When you see a prospective study or a retrospective study, that means that you're either seeing it in real time or you're relying on historical information. So prospective indicates that you identify your group of patients and you follow them forward. Retrospective means that everything's already happened, but you're identifying them and relying on some historical record of what happened. Versus the direction of inquiry, forward versus backward, refers to how we classify the subjects in our study. Are they classified according to their exposure? Are they classified according to their outcome? And we'll get to that a little bit more clearly, I think, with when we get into case control and cohort studies. So the directionality of investigation, along the x-axis here, we have time. So suppose that we're in this gray box here, which is right now. If I'm doing a randomized controlled trial, I start now and I go into the future, right? Everything happens after study initiation. The same thing with a cohort study that's designated as prospective. A prospective cohort is just like a randomized controlled trial, except there's no randomization. Patients just receive therapy. They receive the exposure, they receive the treatment, and you just follow them forward into time to observe their outcome. So you lose the protection of randomization. You're increasing the chances of bias due to confounders. A retrospective cohort is really just like a prospective cohort, except everything already happened. The information contained in the past is all contained in the past, usually through self-recall from the subjects or from the electronic medical record. For the retrospective cohort study, though, the conduct is the exact same, except it's probably cheaper to conduct, right? Because you don't have to recruit people. You don't have to measure anything or provide anything. You just have to go find the data source. Case control also happens in the past, but it's different than the cohort study, and we'll get to that in a moment. And a cross-sectional, notice it's just there. There's no time component. So removing the temporal component between treatment and outcome is why cross-sectional is kind of the weakest among the study designs, because you can't say what came first. You can only say that they're associated. As you move further back in time, anything that relies on historical information has a high potential for bias. So retrospective, obviously, is a weaker study design than prospective. The trade-off in that, though, is that prospective observation costs a little bit more money. So randomized controlled trials look like this. You define your study population, you collect a sample, and you exert control over treatment assignment. So you randomize subjects to either a treatment group or a control. This is a simplistic version, right? There could be 9, 15 different treatment groups here. Could be multiple treatment groups, but for the purposes of demonstration, we'll just do 2. You have a control group and a treatment group, and then you look forward in time through prospective observation to record their outcome. They either had a positive or a negative response to treatment. The key here, and this is why randomization is so important, is because when we use randomization, it ensures that the groups of patients that we're comparing, the treatment and control, are similar in all respects, with the exception of the treatment assignment. So I have some men and some women, but since I'm randomly assigning them, if the study is large enough, I'm probably going to get an equal balance of men and women across my 2 groups. I might have some genetic component, but because I'm using, that's a confounder that I don't know anything about, but since I'm using randomization, I could theoretically balance that confounding genetic factor across the 2 groups, remove its impact and its potential for bias. So that's the purpose of randomization. When we lose randomization, we lose that protection, and we actually increase the risk of confounding on our results. So the strengths of a randomized controlled trial: you have controlled assignment, uniform application and measurement of the treatment and the outcome. When I say that, it's because we have that concurrent control. We're observing the control group simultaneous to the treatment group. The only differences between the 2 are the treatment. So when we see a difference, if we see one, we are assured that it's associated with the treatment as opposed to some other feature of these patients. It establishes the temporal relationship between the exposure and outcome, so we know that outcome came after treatment. And we use prospective observation. The problem with randomized controlled trials, they're fantastic, right? They're rock stars, but they cost a lot of money. They cost a lot of money. And so we often don't start here. We start smaller until we justify the use of those resources, both the patient resources, the time, the investigators, the money, all of it. Another problem that's associated with any prospective study, not just randomized controlled trials, is the issue of loss to follow-up. So unless your randomized controlled trial has the subject sit in a chair, receive an intervention, and their outcome is immediately recorded, you could potentially lose their outcome somewhere because they didn't return for a follow-up visit. They may have passed away from some other unrelated condition. They may have just dropped off the map altogether. And so you have a problem with collecting complete data anytime you have prospective observation. So when you're thinking about your protocol, you have to address that weakness. How can I address loss to follow-up? What are the processes in place I'm going to put to make sure that I'm reaching out to each of these study subjects to get their outcome information? And then if I can't, how will I address that in the analysis? So observational cohort, any questions about randomized controlled trials? Those are pretty straightforward. There are an infinite number of variations on how they can be designed, but that's in general the principles behind their use. Observational studies. At the top of the hierarchy, you see the cohort study, and truly at the top of the hierarchy should be the prospective cohort study. So prospective cohort studies are only better than retrospective cohort studies because they're prospective. So they don't have the weakness of historical recollection. The way that they're conducted is identical to a randomized controlled trial, except the investigator doesn't randomize subjects to the exposures. They just observe some kind of existing exposure status. So let's say there was a workplace exposure or some known exposure that might be happening, pretty frequently in a certain region. We can sample individuals who were exposed and try to get similar individuals that were unexposed. And the reason why we try to get similar individuals who are unexposed is because the similarities between those kind of mimic randomization in some way, right? If we get kind of the same age distribution, the same sex, and other risk factors, if we just try to match them up, then it doesn't predict as well as randomization, but it does kind of mimic it. The direction of inquiry is forward in time. What do I mean by that? Well, we're sampling individuals based on whether or not they were exposed. And then we're following them forward, either prospectively or using retrospective historical data to see what their subsequent outcome was to the exposure. And these are designed to assess an association. You cannot show causal effects in a cohort study because of the lack of randomization. And then there's two defining features, prospective versus retrospective. But they're really, the conduct is the same. It's just, is the data already generated or are you generating the data yourself? So look, it looks just like a randomized controlled trial. The only difference here is we're observing exposure or treatment as opposed to assigning it. And the reason why this is slightly lower on the hierarchy than a randomized controlled trial is because we no longer have the assurance that our two groups that we're comparing here are similar in all respects, with the exception of exposure. We can build into our study design ways of managing that weakness by the way we sample our controls. But that's about all we can do. And then measure as much as we can on them to try to account for the issues. So also, prospective cohort study, notice that everything's happening in real time. The only difference between prospective and retrospective is that you're conducting the study on data that already exists. So you're not recruiting patients, you're not measuring their treatment or their exposure, you're not measuring their outcome. You're relying on someone else's measurement or recollection of that measurement, and that's why it's more flawed than a prospective cohort study. So strengths and weaknesses, it's still like a randomized controlled trial. It establishes that temporal relationship between the treatment and the outcome. You know the treatment came first and then the outcome followed. It's very efficient for rare exposures. Why do I say that? Let's say there's only 300 people in the entire United States who had this particular exposure. How would I do a study to see whether that exposure resulted in brain cancer?
The ability to get those people and do a randomized controlled trial and assign things would be very
well. What you could, yeah,
accrual
would be difficult, right? How many patients would you have to screen before you found one of those exposed people? So it allows you to target those individuals with that rare exposure. And then you could go and you can sample some very similar unexposed individuals and see either short-term or long-term outcomes. What is the result of them having this exposure? So if you have a very rare exposure, then a cohort study is what you want to conduct. If it's retrospective, it's efficient, it's not very costly because the data already exists, and it's also good for the retrospective case. It's also good if, for instance, the exposure that you're studying doesn't produce the disease or the condition or the outcome for a very long time. Because if I were to do a prospective cohort study and I had an exposure of interest that didn't produce a negative outcome for 50 years, how long does my study have to be? At least 50 years long, right? Which is probably not feasible. So retrospective is really good if you know that there's probably a long time between exposure and outcome. The weaknesses, lots of different specific kinds of bias, which we won't go into. Selection bias kind of has to do with the idea that there could be confounding variables that are different between the groups that you're comparing. Information bias and misclassification bias are both types of bias that are associated with historical data, that they don't contain accurate information. And if it's prospective, the same problems that occur with a randomized controlled trial occur here. You might lose subjects and not be able to record their outcomes. They also cost more money than relying on historical data. Going down from the cohort is the case control study. This is usually the biggest question. And in fact, whenever I was first starting out, I would have a hard time figuring out, well, is this a cohort or a case control study? Once you figure out what the defining feature is, it becomes very clear. The difference between a cohort and case control study is the directionality. Not the prospective versus retrospective, but the direction of inquiry. So in a cohort study that we just talked about, it's just like a randomized controlled trial. We select, our interest is in selecting patients with certain types of exposures and then looking forward in time to see what their outcomes are. A case control study is interested in selecting individuals based on their outcome and then looking back to see what kind of exposures they had that might produce that outcome. So that's backwards directional as opposed to forward directional. Is that clear to everyone? It really has nothing to do with if we're following them forward in time prospectively and observing them in real time. That is prospective versus retrospective. This one is a backward directional study because we're selecting our study subjects based on whether or not they have a disease, usually, right? So for instance, I've got glioma cases, and I want to get very similar subjects for my controls that are as similar in all ways to my glioma subjects, except they're healthy. And that will allow me to figure out, well, what could have happened prior to the diagnosis of glioma? What happened to my cases, my sick individuals, that wasn't happening to my controls? And is there any way we can identify something from this vital case control study that we can intervene upon to either prevent or treat glioma? So again, they're designed to test association, and they are retrospective. They are retrospective because the individuals already have to have the disease for them to be a case. So it does rely on historical record. But they're very, very useful studies. You see them, these and cohort studies, all the time in the literature. And trying to figure out how to make this visually work. So we do know in case control studies that the exposure happened prior to the disease. So we have cases which are diseased and controls which are healthy. And then we look back in their medical record or ask them about things that happened prior to the development of their disease, these exposures. So for that reason, we still have the temporal component here, right? We know that this happened prior to the development of the disease. The key is everything happens, though, in the past. All this data has been recorded. The other key is at the top, the backward direction of inquiry. Because again, before all the other study designs that we've talked about have identified our subjects based on treatment assignment or exposure. Here, we're identifying them based on their outcome, which is a disease. And again, just like with anything else where we don't have randomization, unfortunately, we don't have the assurance that the two groups of patients we're comparing, the cases and the controls, are similar in all respects, with the exception of that exposure. There could be other confounding things happening here. But we try to sample our controls in a way that minimize the impact of those potential confounders. Strengths, we still have the timing between exposure and outcome. They're very efficient for rare diseases. So remember, the cohort study was efficient for rare exposures, because if only 300 people were exposed, you can target those 300 people for your study. This is good for rare diseases because we're actually we're trying to enroll subjects with a certain type of disease. So if I know there are only 300 people in the world with this condition, I can target them for my study. And it's also good for studying many exposures simultaneously. We may have no hypotheses about glioma. We might have no clue what's producing this condition, this disease, this awful disease in these individuals. But if we get those, that small pool of cases and a group of healthy controls, we can measure everything about them, right? As much information that was collected, we can ask them questions and try to figure out or generate hypotheses that we might be able to move forward into larger studies. And I just said a term here, generate hypotheses, that I think is important for people to understand. Case control studies and cohort studies generate hypotheses. You can test hypotheses on them. You can report p-values and all that other stuff. But that's not the definitive answer, right? It never will be the definitive answer from an observational study. They generate hypotheses. They don't confirm them. The only confirmation you can get really ever would be from like systematic reviews and meta-analyses. And even that's not quite a confirmation, but it's as good as you can get, as close as you can get. The weaknesses, again, the biggest weakness is that are dependent upon the amount and quality of historical records and subject recollections. So they can have a lot of flaws in them, but they're a fantastic tool for answering questions. And finally, the cross-sectional study, again, it's basically non-directional. It's not prospective or retrospective. It's just there's data on a group of individuals on a population, and we know what conditions they have, and maybe we're interested in, are certain conditions associated? Do they happen together frequently or not? Maybe we're interested in exposures and outcomes, but we don't know for certain the exposure happened before the outcome. And so for that reason, we're just looking at associations, not even X follows Y. And it does rely on data that's already been collected. And so there's no time component. Notice along the bottom here, I don't have any time axis. We just gather data on the exposure or exposures of interest and the outcomes of interest, and we classify them to look for associations. These definitely just generate hypotheses. They don't confirm anything. So the strengths, these are very quick and inexpensive. So if you're just starting out, you might want to look at a cross-sectional study. What data sets or databases or registries exist that have the patient population I'm interested in? And can I go out and access that data and then look for these features and look for associations? You can study many exposures and diseases simultaneously, which is why we often have registries in the first place. And then we can also estimate the burden of a risk factor or the burden of a disease on a population by looking at how many people in the data actually have that exposure or that disease. Weaknesses, again, no timing between the exposure and outcome. You also cannot identify what are called incident cases. So incident means the initial development of a condition, that it hadn't occurred in the past. And so if it's an incident case, it's a new case. Because we don't have any time associated with any of the measurements, we cannot identify incident cases. Additionally, you might also miss conditions that resolve very quickly, either resolve and the patient recovers, or resolve through death. So you might miss those altogether in a cross-sectional study. The last kind of study that we look at, and this is more of a public health type of study as opposed to a medical study, is an ecological study. And this happens when you're collecting data at an aggregate level for a group as opposed to on the individual. So for instance, maybe we're collecting summary information by zip code on all the individuals in that zip code, or in a county, or at a state level. And then we're using that information just at that level, not on the individual person, but on that group of individuals. We're using that summary information to find associations. When we have exposures and outcomes at an aggregate level, we can actually have what's called the ecological fallacy happen. Has anyone ever heard of the ecological fallacy? So an ecological fallacy is demonstrated by these two figures. So suppose that we have, well, I don't even know what this is. We're looking at some exposure along the x-axis. I should remember what this is, but I can't remember. An exposure on the x-axis and some kind of outcome on the y-axis. On the left-hand side, we're measuring, we're taking a measurement of that exposure and outcome at a country level. So what is the average exposure and the average outcome for 4 different countries? And then we're plotting them. And what you see here is as the exposure increases from left to right on the x-axis, the outcome is also increasing from top to bottom on the y-axis. So we might incorrectly infer that the exposure is associated with this increasing condition, increasing rate of this condition. If we were able to measure it on the individuals in the country, though, we might see the figure on the right. So what you see in the figure on the right are clusters of individuals from each of the 4 countries whose information, when it's aggregated, produces that single point. If I look within a country, what's the association of the exposure and the outcome? Is it positive still? It's negative. Does everyone understand how to read this figure? So if I were to draw a line through this scatter to kind of describe how y changes as x is changing, that line would have a negative slope, which tells me that as, at least for country A, as my exposure increases from left to right, what's happening? My outcome is declining. And that's true for all 4 of these countries. It just so happens that the countries differ as a whole from each other on both the exposure and the outcome. And they differ in a way that produces that aggregated positive correlation. So we have to be careful when we do ecological studies that if we're measuring it at the zip code level, at the state or county level, or even at the country level, if it's not measured on an individual people or subjects, we could have this incorrect conclusion. And that's generally called the ecological fallacy. There's quite a bit of information out, even on like Wikipedia, about an ecological fallacy. So if you do those kinds of studies, you have to be careful about it. Here's an example of the kind of public health data that we use to drive policy and decisions. This is actually, it's unfortunate that it's so kind of a controversial topic, firearm legislation. But they were interested in, this is published in JAMA Internal Medicine in 2013, and looking at the kind of the strength of gun laws at the state level and the associated number of firearm deaths per 100,000 individuals. And they only have a measure of those 2 things at the state level. You can't really measure it feasibly for an individual. And so what they saw was a negative association. So all the little red dots are each of the states. This dark line is the the line of best fit to that data. It's basically a regression model that tries to describe how strengthening legislation impacts firearm death rates. But it's, again, at an aggregate state level. And so you see a decline in that. And so the conclusions from this, a higher number of firearm laws in a state are associated with a lower rate of firearm fatalities in the state overall, and for suicides and homicides individually. They do make the important note that their study could not determine cause and effect, because this study because it's an ecological study, really even can't define the nature of the association. So they even say further studies are necessary to define the nature of this association. Even though it looks negative, you might get into Missouri and be able to measure something at a household level or a zip code level, at sort of a smaller aggregate group of individuals, to try to further tease out the association. This happens a lot, again, in public health, which this is a public health issue. It also happens a lot. An example that I use in my classes comes from the 70s with insurance redlining, where in Chicago, a lot of insurance companies got in trouble because they refused to insure minority communities. And that analysis was done based on a zip code level. So you had to dig further down in to find what's going on. And it's very important to further research, investigate things like that, especially when it's a very controversial topic like this, because it can be a heated debate. And someone who is biased against your policy or your conclusion is going to pick apart an ecological analysis very easily. So in summary, and then we'll take some time for questions, I think it's important that as researchers who converse with one another, as policymakers that converse with the public, and as educators who instruct future researchers, it's important for us to always acknowledge uncertainty. P-values provide that really nice black and white decision, but there's uncertainty associated with that, and then kind of understanding what that uncertainty is and what the p-value itself really means is important. That will, if we all take that upon ourselves, I think it'll only strengthen the kind of evidence we produce, and it will allow us to do our research more efficiently, because then we'll reduce the number of researchers out there who are conducting their research in a way that's actually derailing, scientific knowledge. So unfortunately, you won't ever have a perfect study. Every study is going to have limitations for one reason or another. But you should always communicate those limitations and why the limitations existed and why you weren't able to mitigate the limitations through the study design. Every study also has context. So again, as a researcher, it's important that you communicate that context so the people who are reading your manuscript understand how that information should be interpreted and applied in practice. For you all as researchers, though, we also need to take this not only in the way we conduct our own practice, but how we interpret the practice of others, the studies of others. We have to make sure that we understand a study's strengths and weaknesses. We can do that a lot of times relying on the principles of study design, looking at whether or not they incorporated randomization. Has the study been replicated several times? What kind of controls were they using? Did they use blinding? What patient populations was it done in? What measurements are they collecting? Those kinds of things. And we also have to, as peer reviewers of the literature, we have to demand more of our peers in the publication of our results. So you need, in order to be able to even critically evaluate a study, you have to know the information, right? So we have to make sure that we're requesting the information necessary from others in order to critically evaluate the findings of their study. And again, just a reminder, we do all of this, the designing, the careful designing and conduct and analysis of observational and experimental studies in order to isolate a signal and detect it accurately. And the signal could come from an exposure, or it could come from an intervention. I do want to take a minute to plug a tool that I really like because it's free, number one. So I like anything that's free because it doesn't cost anything. And if you have a little bit of time, especially if you're a student, I encourage you to download and start playing around with RStudio. RStudio is a free set of integrated tools that's designed for data visualization and statistical analysis. And it can do more than statistical analysis. You can actually develop processing algorithms and things like that in it. And it has a lot of really cool. RStudio is a company that developed this interface with the language R, and they've developed a lot of videos, a lot of online resources for people who want to learn about it. And just like with anything else that's free, that's also being developed by the scientific community, you can find just about anything about how to perform an analysis or create a plot or whatever in R by Googling it, because there's so many listservs out there, people asking the same question. So I would encourage you to just take a look at that, especially if you have time, which I know none of us do. But okay, any questions about the content today? None. So I was really good, right? Okay, well, if you all don't have any questions, or if you don't feel comfortable asking your question now, feel free to shoot me an email and I can address it at the beginning of next Friday's seminar. Or
Hello?
just shoot you an email back. Did I hear someone talk?
Yes.
Okay, go ahead.
Hi. My name is Juhi, and thank you for the talk. Helped me a lot. I'm a PhD student, and I am designing my dissertation study right now. And and I was just trying to think whether it's an observational cohort study or whether it's a case control study.
Well, I tell you what, you can come if you want to. Do you have like a protocol or a methods section that you're developing right now for your PhD?
Yes.
Why don't you send that to me in an email if it's okay, and then
Sure.
we can either set up a time to talk about it, or I can just shoot you an email back and explain to you why it's one or the other.
Okay, great. Thank you so much.
No problem. Any other questions? Okay, next week we're going to get into probably what you guys are more interested in, which is like, which test do I use? So we'll talk about statistical tests next week. Thank you all for coming.